Hi, everybody. Good afternoon and welcome to this month's edition of Grand Rounds video lecture series. We're going to get started and I'll allow other people to come in as the time goes on. But I'd like to welcome Bhavya Thota. She's from our occupational therapy division. And she's going to be giving us a presentation on the role of Lsvt Big in Parkinson's. So take it away, Bhavya.
Hello, everyone. Good afternoon. So today's my topic is about role of Lsvt Big in Parkinson's. So I'm not sure how many of you know about Lsvt Big. So let's start with. So these are my objectives for today's session. So by the end of session, I wanted to make sure that everyone is aware of what is Lsvt. How is Lsvt Big different from traditional physical therapy? What does the research say about Lsvt Big? Who can perform Lsvt Big? Is it only supposed to be performed for Parkinson's patient or any other neurological conditions as well? So now what is Lsvt Big? The acronym stands for Lee Silverman Voice Treatment. It's an intensive amplitude-based exercise program for the limb motor system. So it is Lsvt Big only if a physical therapist and occupational therapist perform it. But whereas if a speech language pathologist performs it, it's called as Lsvt Loud. So let's go back and see who actually started and how it all came back. So the research began in 1987 when Dr. Lorraine Dramick, who is a speech language pathologist, met one of her patients, Mrs. Lee Silverman, and her family. So when she was speaking to her family members, they have expressed a desire that only they could hear her louder and clearer. So Mrs. Lee Silverman was a patient of Parkinson's. That's when Dr. Dramick started doing extensive research on what exactly Parkinson's patients are suffering from, how the speech is being affected. And so she made a protocol for the Parkinson's patient for the speech treatment, which is known as Lsvt Loud. Now, then a couple of years later, when the extensive research has started in the part of physical and occupational therapy, it started becoming as Lsvt Big. So I'm a physical therapist and I'm an Lsvt certified therapist. So she's Mrs. Lee Silverman, and the whole treatment is being named after her, Lee Silverman Voice Treatment. So Lsvt Big is an intensive, effective one-on-one treatment created to help people with Parkinson's and other neurological conditions to address walking, balance, and other activities of daily living or even job-related tasks. So it's a whole 1 month program and 1 hour sessions for 4 sessions per week for 4 weeks in a row. So there is a daily homework and a carryover exercises. So it's a pretty intense program. So it's technically 16 sessions in a month. So traditionally, we typically schedule a patient for 2 to 3 times a week, which can, for 4 weeks, which can be somewhere between 8 sessions to 12 sessions at the max. But Lsvt Big is an intense program, so it's almost like 16 sessions. Minimum are 16 sessions. It can be extended by a week or 2 based on the patient. Now, why are we looking only at Parkinson's? So let's see the epidemiology part. So Parkinson's is the second most common neurological disease after Alzheimer's. And it is projected that by 2040, the number of people having Parkinson's will be doubled. So currently in the world, there are around 8 to 10 million of people suffering from Parkinson's, and the causes are unknown. So there is still extensive research going on as to why people are developing Parkinson's. So what exactly happens in Parkinson's and what are the clinical signs of it? So it's a progressive neurodegenerative disorder with clinical signs of resting tremors, bradykinesia, postural instability, and rigidity. So when a neurologist or a physician has to diagnose a patient with Parkinson's, the patient has to have bradykinesia along with any one of these clinical signs. And if the patient is responding to carbidopa or levodopa, the patient is diagnosed as Parkinson's disease. There are certain patients who have typically the signs of Parkinson's and do not respond to the medical treatment. So they are called as atypical Parkinson's patient. Now, what exactly happens in Parkinson's? So there is a part of brain, substantia nigra, which is part of midbrain, which is a dopaminergic nucleus, which has a very critical role in modulating motor movement and reward functions as a part of basal ganglia circuitry. So these are the areas which are totally degenerated. So by the time a patient has been diagnosed as Parkinson's, the patient would have already lost a major part of his dopaminergic neurons. So the patient starts presenting with smaller and lesser movements. So the patient typically has bradykinesia or tremors. So generally the Parkinson's is asymmetric. So the patient will have one side affected more than the other. This is a small example of how the substantia nigra will be in a healthy patient and in a Parkinson's patient. Now, what is early Parkinson's? So before the motor signs actually start, most of the Parkinson's patients actually have a premotor or prodromal phase of Parkinson's, which can start as early as 12 to 14 years before diagnosis. So the basal ganglia, apart from having connections with the supplemental motor area, it also has connections to the emotional and cognitive area of the brain too. So most of the patients, before they present with the motor symptoms, they start presenting with the non-motor symptoms, which are typically like reduced sensation of ability to sense the sensation of smell. Then they will even have autonomic dysfunction like hypotension, or they might be having bowel bladder disturbances like constipation. Emotionally, they might be depressed. The patient might even have cognitive impairments. The patient might start having hallucinations and all. So these all also constitute a part of Parkinson's. So now this is where our role comes. The earlier we can identify a patient having these non-motor symptoms, the better is the prognosis. So we can probably, most of us, when we are seeing patients over here, we can see a patient in the waiting area able to repeatedly using one arm more than the other when he's trying to correct his glasses or reaching out for stuff. Mostly he typically uses one arm more than the other. So when we start looking at these subtle signs, it's always better that we talk to the patient and see that, okay, this is what we are observing. Have you started noticing any of these features? Or has any one of your caregiver or people around you spoken to you that, there is a change of you're moving? So have you started moving slowly, or do you feel like your movements have become smaller? So if there is a yes to any of these questions, it is highly advisable that the patient needs to be referred to a neurologist. And from there, once he's diagnosed, he can be referred to the PT or OT or speech as per the requirement. Now, what are the major differences in traditional physical therapy and Lsvt Big? Why is Lsvt Big a better approach than the traditional physical therapy? Being a physical therapist, when a patient comes in, we typically evaluate a patient for range of movement, posture, seeing the assistance in the transfers, gait, balance. These are the typical components which we assess in a patient. Now, when we formulate a plan of care for the patient, we make sure that we start with a range of motion, go to the strengthening, then balance and gait. So this is how, but most of our exercises in the traditional physical therapy are low to moderate intensity exercises. And we do not treat the sensory impairments, which is a major part in the Parkinson's. The patients are having issues with the sensory cueing. So technically, when we are traditionally treating a patient for Parkinson's, we start giving more external cues to the patient as to correct his posture, make sure he's using his arm. So the patient is not able to develop the internal cueing, which is technically the kinesthetic or proprioceptive sense. So he's more reliable on the external cueing, which a therapist or a caregiver gives. So the effects last as long as the external cueing is there. Once the external cueing is cut off, the patient is back to square one. And other component is in the traditional physical therapy, we use compensatory focus. Suppose if a patient is having the difficulty turning from one side to the other, we rather tell the patient how to perform a task easier than actually correcting the problem. Whereas in Lsvt Big, it's a very high intense program. And the major focus of Lsvt Big is about amplitude. So it's about the amount of bigger movements. and sensory calibration. So these are the most important parts of Lsvt Big and how it works in Parkinson's. So the basic scientific principle behind Lsvt is neural plasticity. It is the ability of the brain cells to start forming a kind of a stimulus kind of a pattern when it is exposed to different kinds of external or internal stimulus. So the brain starts forming a neural pattern so that though it's injured, it still is able to perform in a particular pattern. And we follow the same principle of motor learning, which has 3 stages: cognitive, autonomous, and associative stage. So we teach a patient how to perform a task. After that, we make sure the patient is able to develop a skill in it. Before we make sure the patient is developing a pattern, and then we challenge the patient with multiple other things so that he can develop a skill in that particular task. So intensive effort is always required to override bradykinesia and hypokinesia, and that is a major part of Parkinson's. Now, why amplitude? So amplitude is nothing but it's the largest range of motion that can be performed with the highest effort with the most maximally efficient biomechanics. So most of the Parkinson's patient, when we see them, they will typically have flexibility or contracture range of motion issues. That doesn't mean the patient has to have a full 180 degrees of shoulder flexion. So whatever is maximally efficient for that particular patient, that is the highest. And in that particular pattern, the patient has to show his highest effort. Now, coming to the second part, how do we improve the calibration? So we know that patients have sensory problem where they perceive a normal movement as too big movement. So because they're having a sensory motor issue, so they have issues with the internal cueing, the patient is not able to understand that this is the normal movement and it's not too big movement. So Lsvt tries to focus on adjusting the sensory motor system to make the patient understand that this movement is not too big, but it is within the normal limits. So as we start training more of kinesthetic and proprioceptive sense, the patient starts understanding the movement pattern and the amount of external cueing starts coming down from the therapist. So a patient is typically developing more of internal cueing. Once the patient starts developing more of internal cueing, the effect of Lsvt Big starts lasting for a longer period compared to the traditional physical therapy. Now, I'm just showing a small video of how Lsvt Loud patient was before the treatment and after the treatment. As experts along with So this is an example of how she was talking before she was given Lsvt Loud treatment. Now let's see how she's talking after she has got the Lsvt Loud. You can see a couple of other changes apart from the speech. You can see a lot of difference in her facial expressions. Technically, the patient is able to open her mouth more wider. You can see a lot of difference in her mouth opening. Her facial expressions have got much more better. She's able to make the ah sound for a very longer time than compared to the earlier video. So I'm going to show you an example of Lsvt Big. It's a very small video of how the Lsvt Big can improve the patient in his daily day-to-day tasks. Okay. So that's the difference. Once the bigger movements and wider amplitude movements are always used, the patient is able to perform the same tasks in a reduced amount of time. So now what does the research actually say about Lsvt Big? So Lsvt Big has initially been started in 2010. So there is a quite extensive research about how Lsvt Big can improve. So they have seen certain improvements in gait speed, trunk rotation, balance, walking, and improved ability to dual task. So I have taken a couple of articles where so that I can show a difference between Lsvt Big and a traditional outpatient physical therapy. It was done in 2013 by Farley and Koshland. It is a randomized comparative pilot study where there were 42 Parkinson's patients who were taken and who were in the stages of 1 to 3 in the Hoehn and Yahr scale. So they matched the frequency and the duration. So what frequency means is traditional physical therapy was also done 4 times a week for 4 weeks. And Lsvt Big is also done 4 times a week for 4 weeks. And they have seen that these are the outcomes they have noticed, like balance, mobility related quality of life, trunk rotation, and ability to perform dual tasks and walking. So when they have observed the differences, these were the strange findings. So balance improved in both the groups, the ones who had Lsvt and the ones who had traditional physical therapy. But the Lsvt Big had a lasting effects for 3 months post-treatment, and the effect sizes were twice more than the traditional physical therapy because of the cueing part. Now, the trunk rotation outcome was only seen improved in the Lsvt Big group, and quality of life and walking were improved in both. But again, there was no lasting effect of quality of life and walking in traditional group. Trunk rotation and ability to perform dual tasks were the 2 important components which were found only in the Lsvt Big group, but not in the traditional physical therapy. And ability to perform dual tasks is one of the most important component for a patient who is staying alone in his house. So there was another article where they have seen that what if the dosage is reduced, is the outcome still the same? So 4 times a week for 4 weeks, 16 sessions is quite intense. So they wanted to see if actually the 16 sessions are required to have the same outcome, or can it be reduced? So they did a small randomized study where they compared Lsvt Big, which is 16 sessions, and they made a short training protocol, which is typically amplitude based, but we cannot call it as Lsvt Big because Lsvt Big has to be done 4 times a week for 4 weeks, and each session has to be an hour. So they did 5 sessions for 2 weeks, which is 10 sessions. So they compared 10 sessions versus 16 sessions, and the outcomes was patient-rated outcome scores. So it was done by Ebersbach et al. In 2014. So he mentioned that the reduced training intensity may not have been sufficient enough to obtain the main goal of Lsvt Big, which is recalibrating the movement amplitude to secure improved motor performance in routine activities. So basically the calibration effects were not long lasting if you are doing only 10 sessions. So 16 sessions showed that the patient was having a long lasting outcome. So what exactly is done in Lsvt Big protocol? So we are not going to do the typical gait training or balance training or components of how we typically manage a patient when the patient comes in for physical therapy. So Lsvt has a very strict protocol, and this is the same protocol we need to use if the patient is an ideal candidate for Lsvt Big. So it is divided into 4 components: maximal daily exercises, functional component tasks, walking big, and hierarchy tasks. Now, what are maximal daily exercises? There are a set of exercises which are supposed to be performed either in standing based on the patient's condition. If the patient is having good balance, then they can start with standing exercises. Or if the patient is not having a standing balance or has some other comorbidities where the patient cannot be put in standing for a very long time, then seated exercises are also available as an adaptation. And at the same time, for patients who are in the higher stages of Hoehn and Yahr, stage 4 and 5, they can also perform Lsvt Big exercises in supine. So these are the exercises that are supposed to be done. Each exercises needs to be done for 8 repetitions. If it's supposed to be done on both the sides, each side has to be 8 repetitions. Now, once these maximal daily exercises are performed, then we go to the functional component tasks, which are like a typical simple component task which a patient uses in day-to-day life, like sit to stand, opening the doors, closing the buttons, or something like that. So we are going to pick up some 5 functional component tasks from the patients while the patient is, during the evaluation, the patient complains, so these are the activities which I'm not able to do. So we are going to pick up the functional component task during the evaluation and train the patient in the same task. Then comes a walking big. So we are going to make sure the patient is taking bigger and wider steps and making sure there is arm movement and trunk movement. So the initially first few sessions, the therapist is going to be giving external cues. Later on, the only cue from the therapist will be walk big, move big. That's it. So we are not going to tell the patient that you need to control your, you need to make sure you're lifting your foot, make sure your trunk is upright, make sure you're moving your left arm. No multiple commands. It's just move big, walk big, take big steps. That's it. So the patient has to adjust his posture and walking so that he takes a bigger movement. Now, the last one is a hierarchy of tasks. These are the complex tasks which a patient will be using but has a component of functional component tasks. So like, for example, playing a golf. If a patient is having some particular hobbies, and if the patient is being stuck in those particular hobbies, we can include those as a part of treatment so that in the future, when the patient has completed the Lsvt Big protocol, the patient is still able to perform these tasks. So now the question comes, is Lsvt supposed to be used only in the Parkinson's, or can other neurological conditions also use Lsvt Big protocol? Yes, there are a lot of other Lsvt Big patients who are using, apart from the Parkinson's, these are the patients who can use Lsvt Big treatment approach. One is brain injury, balance and falls, atypical Parkinsonism, multiple sclerosis, stroke, and spinal cord injury. So any patient who has these type of conditions, we can still use Lsvt Big. It doesn't mean that Lsvt Big is only supposed to be used in Parkinson's. Any of these conditions also can use Lsvt Big, but the protocol needs to be the same for any patient when they are using Lsvt Big. So how do we decide whether Lsvt Big is appropriate or not? So these are the questions we need to ask ourselves as evaluating PTs. Is there a muscle activation deficit? Is there a problem with sensory processing? Is the patient responding to stimulability testing? Is patient medically stable? The reason why we are seeing the medically stable is because, as I informed you, that Lsvt is a high intense movement based approach. So if the patient is not stable, then it's not an ideal time to start Lsvt Big. If the patient has cognitive impairments, is there a support system in place? Now, if we get yes to these questions, then the patient is a very ideal candidate for Lsvt Big. Now, what is stimulability testing? How do we know whether the patient will be able to have a better outcome post 16 sessions? So what most of the researchers advise is try to make sure that the patient is trying out the exercises of Lsvt, the amplitude-based exercises, for a week or 2. See whether there is an improvement in his amplitude, if his movement patterns have been changing, is the patient benefiting from internal cueing? So if yes, then yes, the patient is a right candidate for Lsvt Big. Now, are there any conditions where Lsvt Big is not appropriate? Yes. So amyotrophic lateral sclerosis, acute multiple sclerosis exacerbations, acute hemorrhagic CVA, acute phase of myasthenia gravis. These are not the ideal conditions where you can do Lsvt Big. Or some other immediate acute surgical conditions, post-surgical conditions like recent hip arthroplasty or something. So in those conditions, we might have to wait it out and then start the Lsvt Big protocol. So whenever a therapist is starting Lsvt Big protocol, the patient has to attend the 16 sessions. Of course, there would be times where it is kind of extremely difficult for the patient to attend all the 16 sessions. 1 or 2 here and there are fine, but still towards the end, the patient has to finish minimal of 16 sessions. It can extend beyond that, but the minimal requirement is 16 sessions. So does the order have to be different for a Lsvt Big protocol? No. From the physician, the order will be still the same: evaluate and treat for PT or OT. So once a patient is an ideal candidate for Lsvt Big, so we can go ahead and start scheduling the patient for 16 sessions. And most of the insurances do cover Lsvt Big. We should not be having any issues with the reimbursement. So this is the last video of Lsvt Big, how the patients are having a difference with the Lsvt. You can just watch the video and see the difference. This is the patient is, they are trying to do a timed up and go dual motor test, where the patient is holding a cup of water and walking. They're checking the time. So this was pre-Lsvt Big. So this is a patient who has been struggling to wear a jacket, and he almost takes a minute or so to put on his jacket. But the same patient, he will be able to put on his jacket in less than 30 seconds post Lsvt. So it increases the patient's performance after the Lsvt Big protocol has been performed. But once the Lsvt Big protocol has been performed, now what are we supposed to do next? The patient will always be having carryover exercises. So the patient can come back for a tune-up, which is technically once a patient is discharged from the Lsvt Big, like he has completed his whole protocol, he's able to get his amplitude back and he's able to perform. Now, but Parkinson's is a progressive disorder, so we can expect the patient can get worse later on. So it is ideal for the therapist to schedule the patient after 6 weeks for a reassessment, 6 months or 3 to 6 months, or based on the patient, or even 12 months later, just for a reassessment. Based on the reassessment, if the therapist finds that, okay, the patient is really still having a good amplitude, maybe he needs a little bit of tune-up, so we can do a 1 or 2 sessions, which are not called as Lsvt, but still we are going to use amplitude-based movements. So once the patient is tuned up with his exercises, then we are going to discharge the patient again with a home exercise program, and the patient is going to continue. So a part of home exercise program is like the patient has to do the functional component tasks, which are typically like the sit to stand, simplest task, forever, at least 1 repetition each day. The patient will be continuing the same exercises lifelong till he is able to maintain the amplitude. So it's never ending. So coming back to my objectives when I started this particular presentation. So what is Lsvt? Yes, we do know that it is Lee Silverman voice treatment, which was initially started by a speech language pathologist. Her name is Dr. Ramick, and it has extensively started again in the physical and occupational therapy, which is called as Lsvt Big. Now, we do know that Lsvt Big is different from the traditional physical therapy because it's more amplitude and high intense based exercise approach. So research has a very strong evidence that Lsvt Big has a better outcomes than compared to the traditional one, especially in terms of dual task and trunk rotations. Though the other ones have also improved in both the groups, but the effect stays longer in Lsvt Big treatment groups. Now, who can perform Lsvt Big? All the certified Lsvt Big physical therapists, physical therapist assistants, occupational therapists, and occupational therapist assistants are allowed to perform Lsvt Big. So if a patient is scheduled for Lsvt Big treatment, the treatment has to be given and delivered only by the Lsvt certified therapist. So if the therapist has a day off or so, that treatment which is performed by someone else cannot be counted as Lsvt Big treatment. So is it only for Parkinson's? No, it can be used for multiple other neurological conditions as well. So this was a small sketch which was actually drawn by one of the patient who attended Lsvt Big seminar. It was an educational seminar on how a patient can benefit from Lsvt. So the first image was how he felt when he actually walked in, and how he felt after he heard the whole seminar, and how much Lsvt Big can make a difference in his life. So walk big, talk big, and move big. So any questions?
I have a question. How many patients does Insight Comprehensive Therapy treat using Lsvt Big?
So currently we have only one patient who is actually diagnosed with Parkinson's. Since I have started working in the outpatient physical therapy here, we do not have a lot of Parkinson's patients. But that's the main reason of my presentation, because we have a high potential that we can tap a lot of patients, because there are so many Parkinson's patients who can be referred for physical therapy or occupational therapy or speech therapy, and they would have a huge benefit from it. So currently we are having really low stats, but it's all about the neurologists and neurosurgeons. We have so many well-renowned surgeons and neurologists around here. So that's the reason I have presented this topic.
Yeah, because I think it would be beneficial to document the progress of patients
right.
with this therapy. I think Evan also has a question.
Yeah, you mentioned how this program was different from like traditional physical therapy treatment plans. I was just curious, do we use like traditional physical, occupational, even maybe massage therapy in combination with this particular program?
So when we are actually following the Lsvt Big protocol, it's a very standardized protocol, which I have mentioned that they use the same set of exercises, which they can be modified here and there, can be adapted as per the patient's comorbidities. Apart from that, when we are following the protocol, it's just the protocol. Along with that, we can definitely add a part of manual therapy if that is something which is medically required for the patient, but that cannot come under the Lsvt Big protocol. So they are very particular about the protocol. So it has to be the same way how they have designed it.
Gotcha. Okay. So you have to follow this specific criteria.
Yes, that's correct.
Okay.
Okay, cool. If anybody else has any questions, I've given you the option to unmute yourselves, or you can type it into the chat box if you don't feel comfortable, and I'll ask Bhavya. All right, last call for questions. Okay, if we don't have any questions, I'd like to thank everybody for joining us on this month's edition of Grand Rounds video lecture series. And as always, please follow us on our social platforms, LinkedIn, Facebook, Instagram, and even TikTok. All right, have a wonderful rest of your day. And thank you again, Bhavya.
Thank you so much. Thank you, everyone.